Well, the 10-year results of the START trial were published just a few weeks ago, so I sort of presented those to the audience, and it confirms the hypothesis that had been under test, that breast cancer is as sensitive to the size of the daily dose, or what we call a fraction, as the dose-limiting normal tissues, which means that continuing the historical practice of giving lots of small doses, that we're sparing the breast cancer as much as we're sparing the healthy tissues. In other words, there's no advantage to that practice. And that a 15-day schedule of radiotherapy is as safe and non-inferior to a traditional 25 fraction 5-week schedule. And so that has been standard of care in the UK and increasingly in other countries for several years now. So since then we are conducting a trial which is evaluating a 1-week course of radiotherapy against a 3-week standard, so-called fast-forward trial. That's been running for 2 years in the UK, and it's just recruited its 3,000th patient. So that'll finish accrual in about 3 months' time with 4,000 patients, and we would hope then within 5 years to have a curative treatment of radiotherapy for breast cancer patients, which would involve 5 days, 1 week of therapy, and that's clearly a very good proposition. I mean, at the same time, we're interested to know whether all breast cancers are equally sensitive to fraction size. We know they are on average, so one of the translational priorities for the next 10 years is to actually identify whether there's a wide range of sensitivities that we can actually exploit and stratify patients to, whether that stratification might be generalizable to other cancers, for example. So that will be one avenue of future translational research. Another would be that the 3-week schedule performed in our trial, START trial B, slightly better than we expected it to be. Not only did it appear non-inferior, but in fact local control was 1% better than in the 15 fraction arm, in the 25 fraction arm. And if that result were to be representative of breast cancer response to radiotherapy, it would suggest that treatment time is much more important than we thought. In other words, the shortening from 5 weeks to 3 weeks of itself had a therapeutic effect. And if one does fairly simple calculations, it would mean that about 0.6 of a Gray, or maybe 25% of our daily dose, is in fact compensating for proliferation overnight and over weekends. That's an interesting proposition, and that is certainly known already for other cancers, head and neck cancer, for example, where we treat over the weekends for that very reason, but it's never been considered in the context of breast cancer. Well, to the extent that breast cancer we've demonstrated is on average sensitive to fraction size, then we stratify our cancer patients into by breast cancer type, and we then allocate them, if you like, a stratified schedule, the 15 fraction schedule, which we didn't do before. And as I've just mentioned, if we can identify biomarkers that would actually measure an individual's likely sensitivity to fraction size, we would then start to stratify subpopulations of patients. That would be a long-term research aim. And by long-term, I mean a 5 to 10 year program. But that certainly would be certainly a realizable research objective, and we would hope would be generalizable beyond breast cancer to other tumor types.